Just the Niagara Regional Campus recognizes and acknowledges that we are located on the traditional territories of the Haudenosaunee and Anishinaabe nations. This territory, covered by the Upper Canada Treaties, is within the lands protected by the Dish with One Spoon Wampum Agreement. I'd like to introduce Jodi Rock. She currently holds the position of Indigenous HealthLinks Transformation Lead, working to support the scale and spread of HealthLinks model of care within Hamilton, Niagara, Haldimand, Brant, Lynn. She is Mohawk Nation, Turtle Clan from Six Nations and New Credit communities. Prior to this role, she supported Indigenous community members through residential and transitional programs for victims of domestic violence, chronically homeless, and survivors of human trafficking. She has also supported Indigenous families within the child protection system, utilizing Indigenous models of dispute resolution. She was the inaugural Aboriginal patient navigator for Hamilton when the program first rolled out in 2013, and continued to support Indigenous community with involvement as a patient and family advisor leaving after that role. She is passionate about supporting meaningful engagement and partnership development between Indigenous and non-Indigenous led organizations, about improving upon Indigenous patient experiences, by supporting the advancement of Indigenous cultural safety within a historically anti-angiogenic discriminator system. So, thank you very much. We're happy
wow.
to have you.
Words that come before all else. Thank you, Creator, for getting me out of bed this morning and allowing me the opportunity to come and share information, and to thank you as well for coming with open minds to learn. So I'm just going to give a little background about my role. As it was mentioned, I do hold the role for Indigenous HealthLinks Transformation Lead. What that role is to do is to support the scale and spread of the HealthLinks model of care within the Indigenous community on reserve and off reserve throughout the entire LHIN. So that's Six Nations, Dunnville, all the way to Niagara region. The HealthLinks model of care, if you don't know, it's a model of care that wraps supports around patients with complex health conditions. These supports could be social, they could be traditional health supports like we may know. The model of care is patient-centered, so it's directed by the patient goals. It's very similar to what our original instructions tell us and how we're to care for our vulnerable and our sick. The start of my role was going out into Indigenous community and saying, hey, the province has this new tool, this coordinated care plan. Let's get on board to filling out these coordinated care plans and be part of this official rollout for this model of care. And what I heard was, Jodi, come on, you know better. We know we do this already in our communities. It's not something new for us. Even patient-centered, it's how we do things. So no, we're not interested. What came out of that engagement was the need to address cultural safety on a system level and also on a patient level. So on a system level, we're looking at engagement, partnerships between Indigenous and non-Indigenous led organizations and institutions such as hospital, building those care teams around that patient. On a patient level, it was the cultural safety that our Indigenous people did not experience, I guess, when they engaged with hospital. So the lack of cultural safety for our Indigenous patients. What I was suggested to do by our Indigenous stakeholders is to go out there, focus on building capacity within non-Indigenous led organizations on how to respectfully engage with our Indigenous patients, and also build meaningful partnerships with our Indigenous stakeholders. So that's where this presentation came from. I roll my eyes a little bit because I'm essentially coming out here and telling you how to engage with me as an Indigenous person, but it's really important to have some refreshers to those key concepts within the teachings on cultural safety, what that means, and also empowering you to go out and be better prepared to build those partnerships with our Indigenous stakeholders on a system level. So that's how this presentation came to be. I'm very grateful to be here. So we start with information that comes from one of our traditional knowledge carriers back on Six Nations. This is Leroy Hill. He speaks about the Haudenosaunee and a strong belief and commitment that we need one another. If one is suffering, we are all responsible to help that individual recover. He goes on to say, Haudenosaunee cultural teachings speak of never judging others, but rather using encouragement to help individuals to reach their own good-minded realization of the need to change. We are encouraged to practice self-reflection as a means to remain on a good path in life. really, when we look at engagement and relationships of any sort for our Indigenous people, it's a reciprocal relationship. And this is not just unique to the Haudenosaunee, it's generalized across Indigenous people, the Anishinaabe as well. We're students and teachers in all interactions. So I'm going to keep coming back to that, because building that relationship with a patient or with another care provider, there's humility in accepting that we are teacher and student at the same time in all of those interactions. And he's talking about the responsibility that we have to come together. They go on in some of our teachings and talk about the responsibility to engage other care providers as well. You don't take on that burden yourself, you share the workload. So again, this model of care is very much part of our original instructions and how we care for one another. Six Nations has a traditional medicine program. They go out and they do education on cultural safety. And I really like what they've done with that, because they've rebranded it. So instead of calling it cultural safety, they're calling it community safety. And they define it as a reciprocal relationship between a community member and a service provider. The respect and trust within this relationship creates the space for a person to voice their needs based on their values and beliefs. So essentially, it's a relationship that allows the individual to be just who they are, is how they define it. So when we're looking at something like HealthLink's model of care and patient-directed care, that's really important, to allow that patient space to be whoever they define themselves to be. So I really like that cultural safety has been rebranded as community safety. And when I go out and I talk about HealthLinks, building that capacity for cultural safety supports all patients, whether they're Indigenous patients, whether they're patients that live with chronic homelessness, mental health, addictions, a lot of those issues that see our community members marginalized and living with stigma and discrimination. Building that capacity to create that culturally safe space supports all patients. So there's a study, in the slide deck there's links to all of these documents, but there's a study that comes from up north. It was done from the First Nations and the surrounding public health units. And it was specifically looking at relationship building between those non-Indigenous led institutions like the public health departments and the First Nations communities. And what came out of that was some best practices, or wise practices they call them, and some central concepts to that relationship building. So it starts with respect. We start in the east and we always go around. It starts with respect. It goes into trust, self-determination, and commitment. Now, what I see when I go out is respect and trust may be concepts that are easy for people to grasp. It's the self-determination and the commitment where a lot of the partnership building tends to lack. So I'm not going to read all of this. You can have that after, and I'm going to go very quickly because I know we're limited in time. But that relationship building, you can start that respect, laying that foundation through things like cultural safety courses. So the LIN funds the Sanyos Indigenous Cultural Safety course. It goes over some historical things, some things to be aware of. That's understanding and appreciating the differences between our experience as Indigenous people and mainstream society. One of the things that was mentioned in the community safety training from the Six Nations Traditional Medicine Program, attached to this slide deck, there is the actual article from Claire Brandt. Claire Brandt was a Mohawk psychiatrist, and he looked at communication styles within Indigenous community, and he looked at how conflict suppression, or how that harmony was maintained, and he came up with these 8 principles. In his work, he looked outside of Haudenosaunee, so he wasn't restricted just to, examining Mohawk ways of being. He looked outside of Haudenosaunee, and he found that these differences in communicating could be generalized to Indigenous people in general. There's a couple that are highlighted there. One of the things to keep in mind is some of these differences in how we communicate and how we see the world, even though they may seem kind of abstract and kind of behind the scenes, they really come into play in our interpersonal interactions, our relationships. So again, because I'm Health Links, I always go back to Health Links, coordinating care, wrapping care around patients with complex health conditions. We look at a situation where maybe you're trying to get a patient interested in actually completing a coordinated care plan, putting those care team members around that patient. You may be in a position where you're suggesting maybe a treatment plan, or you're suggesting course of action. If we look at the first principle there, the non-interference, and again, we go back to that first slide where we say we're students and teachers in all interactions. Students and teachers all the time. In that situation where an expert is maybe presenting a treatment plan, the patient, if that was myself, I'm going into that interaction thinking, okay, well, that person's here to learn from me just as I'm here to learn from this person. So they're sitting there and they're telling me that I should do this, 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 and this, and this. And meanwhile, I'm sitting here and I'm thinking, okay, in past conversations, you didn't hear when I said this. You are forgetting that this is part of my reality. This is not going to work for me because of this reason. I may be thinking about all these reasons why this care plan is not going to work for me. I am still looking at the interaction where both students and teachers at the same time. I'm not going to speak up and say, hey, that's a load of crap. It's not going to work for me. I'm going to step back and let you come to that good-minded self-realization through self-reflection that something's not right here. So I hear often in my work about Indigenous patients, well, they don't complain. I didn't know, and that comes again back to our differences in communicating and that idea of emotional restraint. So we're not going to express that we're upset. And again, we can't generalize to all Indigenous people because some will quite vocally say, hey, I don't like that. And we can't, expect that they're going to be voicing those differences in opinion. Could be because they don't want to be that interference in your own good-minded self-reflection. We look at the non-competitiveness and the sharing. I used to work in a homeless shelter supporting chronically homeless individuals, survivors of human trafficking, and I would get individuals sitting in the chair in front of me and I would be trying to say, okay, you can access this service, you can get support here from this, and I could almost see them pull back a little bit and say, no, I don't think so. So having that conversation with them and exploring why they don't want that referral, why they don't want to follow through and access this program or this service, what I heard was, there's somebody out there that could use this more than me. And that comes down to the non-competitiveness and the sharing. We don't take more than what we need, and we always make sure that there's something left for everyone else. So there had to be times when I had to, lovingly coach them through a reality check, like you're in a homeless shelter, like you deserve this, and kind of have that conversation with them to help them see that they are just as deserving as someone else. So even though these differences in communicating in these principles, they may seem kind of abstract, they do filter down to very concrete differences in how we communicate. So understanding those differences, appreciating those differences, it's laying the respect for trust within that relationship, laying the foundation for respect and the opportunity to build trust within that relationship. So this is something that comes out of the Thunderbird Partnership Foundation. It's a cultural safety toolkit. It's got some very practical things on there. I'd like to see it pinned up at emergency departments, nurses' stations, everywhere, just to remind people. One of the things that I found interesting out of here is this. So when you're talking to somebody and you're saying, hey, I think maybe you should go and get this test done or do this course of action, and they're nodding, in our traditional culture, it doesn't necessarily mean that they're agreeing. What it means is that they're hearing you and maybe that they're understanding, but they're not in agreement. But mainstream Western culture may look at that nodding and say, okay, yeah, she's on board, she agrees with me. So it's two very different ideas. Different things on there, and again, this will come out afterwards with the attachments, but these are part of the things to be aware of, again, in laying the foundation for that respect and trust. So Claire Brandt, his study that was put out, I think it was early 1990s, 92, something like that, early 2000s, they took those principles and what they did is they educated physicians. And they said, okay, physicians, you work with Indigenous community members. We're going to give you this knowledge on the differences in communication. We're going to, have you supported in that learning. We're going to put you back out to practice within those Indigenous communities, and we're going to see what happens. So it was a very interesting study. Again, it will be sent out with the links, but this is what a physician has to say about that experience. So he recalls the sense of humility that comes with understanding your limitations. I could illustrate with a quick story. I saw a very elderly Native lady. Her daughters brought her in. She was sort of a matriarch, and they called me that night and asked me would I come to the house and see her, and I did. Normal pulse, normal blood pressure, chest was clear, everything seemed fine, and I had no idea why they called me out at night. But I was pretty annoyed that they had done that. When one of the daughters said to me, would you like a cup of tea? And I said, sure, that would be great. And that sort of diffused my little reprimand. I went into the kitchen and sat down to have my cup of tea, and while I was having the tea, the daughters went back into the bedroom, and then one of them walked out and said, while she's gone, very peacefully now. And I said, what? And ran into the bedroom. She was lying there dead as a doornail, and they said, thank you very much for coming when Mother died. We knew she was going to go, and we really appreciate just you having been here. I thought to myself, well, first of all, am I ever glad that I didn't say what I intended to say about the unnecessary visit? And secondly, how in the hell did they know she was dying? I honestly did not have a clue. That injected in me a great sense of humility, like, whoa, they know a lot more that I don't know about their mother, but also just about death and dying. And anyway, I've held on to that sense of humility, and that's pretty much where I remain. So I really like that story because the physician, moves from that place of being irritated because they were called out of bed and they went out, but to really recognizing, learning in that opportunity. So he was an active participant in learning from that experience. He was a student in that experience as well, that reciprocal relationship again. That study talks about the power of the silences. So the physicians and how they've changed from those interactions with patients where silence was not part of that interaction typically, there were no silences, but how they learned to really appreciate those silences and how that opened space for more meaningful engagement and better relationship development. So if you can, check it out. It's very interesting. So again, we talk about trust. So after that, respect is there, appreciating the differences, understanding why there's historical lack of trust towards non-Indigenous organizations like hospitals, healthcare institutions. There's a link to a document called First People's Second Class Treatment. What they've looked at in that document is specifically anti-Indigenous discrimination within the healthcare system and how that affects Indigenous patients. So takeaway point from that is it's the lack of assessment, misdiagnosis, lack of treatment, and death. So even though these things are talked about in these scholarly articles and these documents are published, we have this experience within our families. Being a culture where narratives are passed down through stories, we hear about experiences like this, and we have had these stories or these histories as part of our narratives within our families and our communities for a very long time. So I want to keep that in mind as well. Going back to this, one of the things I learned in taking the Indigenous Cultural Safety course through SANYOS or SOHAC, it's called Southern Ontario Aboriginal Health Access Centre. It's the course that the LHIN will subsidize. If you work for a LHIN-funded agency, you can take this course. It's 8 weeks, it's online. It's really great learning. I didn't understand until I took that course about the segregated care. So as an Indigenous person, I would be offered alternatives to care, and I would just feel some kind of displeasure when they presented the Indigenous stream of care to me. I didn't understand why until I took the learning and I was reminded about the TB hospitals and how at a point in history it was a very deliberate action in terms of the government to channel Indigenous people to hospitals that provided substandard care. And then I started thinking about the narratives that I would have in my family about, oh yeah, well, you only went there if you wanted to die because they didn't have the same kind of nursing, they didn't have the same kind of treatment. You didn't want them to know you were Indigenous because if they knew that you were Indian, then they would send you to that Indian hospital and you'd certainly, you know, have a bad outcome. So those are the kind of narratives that I remember hearing growing up. And really, some of this distrust happens underneath the surface where we may not even be aware of what the roots of that are. All we know is that when we go into an organization like a healthcare institution, or we're dealing with an expert like a medical professional, we have that underlying distrust and fear. We may not be able to connect it to the roots, but that's part of our experience. So in terms of partnership building, and again, keep in mind that I speak about cultural safety at a patient level and also cultural safety at a system level. One of the things to really be aware of is our relationship with our health information. And that's where OCAP comes in. OCAP stands for Ownership, Control, Access to, and Possession of First Nations Health Data. So going through that learning, understanding, you know, some of the historical things that have happened with our health data, it really helps you understand why Indigenous people may clam up. They may not want to share information about, you know, traditional practices that they want included in their care. They may not be able to even share basic information about their Indigenous identity because there's that circle of protection around our health information. When you're looking at building partnerships, one of the things that you can do is, again, we're going into the self-determination piece, but how can this relationship support self-determination? Self-determination of that patient, self-determination of that community. So that's where some of these practices come in place, where your communication, what you're writing down, you're very transparent with. So you're recognizing that there's a lack of distrust there and maybe offering them to look at what you're writing down, maybe including them in conversation so that they can have that assurance that, you know, you're not talking about them in a bad way when they're not in the room. So just keeping in mind that there's some special considerations to our health information, and you can build that capacity through going, and it's about a month training online. It's very simple training, or you can even read the brief on it just to learn about OCAP and what that means for our healthcare information. Trauma-informed care is something that I really speak about a lot because it really shifts the perspective from what's wrong with you to what happened to you. So I believe that all of our services should be trauma-informed in that sense, where they're meeting patients where they're at. You're constantly checking in to see how they're doing, how are they accepting what's presented to them. So that's something I often push. And again, we talked about self-determination, and when it comes to our health, whatever can be done to support patient direction. So with Health Links and the coordinated care plan, it's all about the patient goals. The patient goals may be totally different from physician goals. They may be totally different from hospital goals, but it's the patient goals that directs that plan of care. So getting back to that practice of putting the patient at the center. So when we look at asking about Indigenous ancestry, because you can't build care teams that are inclusive of Indigenous supports without knowing if the person is Indigenous. You know, me, yes, you can look at me probably and guess that I'm Indigenous, but there's a lot of people out there where you can't guess just by looking at them. So what that comes down to is it appropriate to ask? How do I ask? What can I expect if I ask? In the Health Links work, what I found is that the system was set up to capture Indigenous identification, but the human resources part of that system where the people weren't comfortable asking the question, so they just skipped over it. And what that meant is, again, we go back to self-determination of the Indigenous community. What it meant is that those outcomes for specifically Indigenous population were not able to be captured because that checkbox wasn't checked off. So we weren't able to really describe our Indigenous patient experience. So a lot of going out and engaging with the stakeholders, that's kind of where I started. How do you ask? If you're going to ask about Indigenous identification, recognize that that health information or that information around that patient should be protected by OCAP. So, be aware of how you report on that information, how you share that information, but even going to a group of frontline workers and saying, okay, let's talk about the ask. So some of the things to consider if you are going to ask about that is why you are asking, and fears that the patient might have to disclose. I'm not going to go over any of that because there's a really cool video here to watch. And this video was done to support the homeless sector in Hamilton because the shelter workers did not feel comfortable asking.
This video provides some guidance to frontline staff on asking the question, do you identify as Indigenous or have Indigenous ancestry, as outlined on the common intake form used by all agencies in Hamilton's homelessness serving system.
So this question may be uncomfortable for some people to ask because Indigenous is a label, a product of colonization. Some people may have negative reactions to the particular word Indigenous. So we're just exploring on different ways on how to ask that question and be sensitive.
Hi, how are you?
I'm fine, thank you.
I'm just going to ask you a few questions if that's okay.
All right.
Do you identify as Indigenous or as having Indigenous ancestry?
What does that mean?
I'm sorry, I'm just reading the words off our intake form. What I mean is, do you identify as First Nations, Aboriginal, Native, Métis, Inuit?
Okay, yeah, I'm Native. What do you need to know?
I'm just asking so that we can make sure that we refer you to the most appropriate services based on your preferences. And just because you identify as Native does not mean that you have to work with a Native agency, and you are free to change your mind at any time.
Okay, right now I kind of would prefer not to work with a Native agency. Not in a very good place right now, and sometimes when I go into Native agencies I run into people that I know, and I just prefer not to right now.
Okay, thank you for sharing.
Take-home points to remember. Indigenous, Aboriginal, Native, Métis, First Nations, Inuit, those are all labels, product of colonization. It may not be how we prefer to refer to ourselves. If you're getting a negative reaction from somebody, please remember that that reaction is to colonization. It's got nothing to do with you. Please don't take it personally. Understand what's behind that. Different generations may relate to different terms. For myself, I relate more to Aboriginal or Native. However, I will acknowledge being Indigenous or First Nations. Younger generation may relate more to Indigenous. If a person is saying to you, yes, I'm Indigenous, it's okay to reflect that back. It's even okay to ask them, how do you prefer to be referred to. You can ask open-ended questions. If you don't get an answer to that right away, you can go back and revisit that after you build some relationship with the client, changing the answer when you get the new answer. You can look for symbols that in the environment. The person may have a pin on, they may have a tattoo, they could have a dream catcher necklace. So different symbols may indicate pride in their identity. You can use that to open conversation to ask about their ancestry. You can make your space more inviting by putting some things in that room. You could put in posters, sculptures, Indigenous artwork from the Indigenous community, different things like that. Be sure to check in with the Indigenous community about the appropriateness of the items that you want to display. To make sure there's no protocols around how they're taken care of, that they're not tacky, that they are appropriate. Another thing that you can do is acknowledge the traditional territory on where your shelter or your building is situated. So it could be something simple like a little sign up in the intake area, acknowledging that this is the traditional territory of perhaps the Haudenosaunee, Six Nations Iroquois people. So make those efforts.
be committed to reconciliation, consult with Indigenous community, agencies, community members. We all have a responsibility to work towards reconciliation. Let's all be committed and work towards that in meaningful ways.
Okay. So that was very well received within the community in Hamilton, and it has been shared with permission from Core Collaborative Learning to the frontline providers. You've seen some key points there. For myself, with my generation and my age, yes, I would call myself a Native person, and you've seen how she took that and she reflected that back to me after she heard me say, yes, I'm Native. She didn't get offended when I said, why do you need to know? Like, what's it to you kind of thing. She went back to exactly what was on her paper and just said, oh, I'm just reading it as it's on the paper here, but this is what it could mean. So again, making space to build that relationship rather than just focusing on the question as it read. Some things to keep in mind from that. For an older generation person, perhaps like my mom or my older aunts and uncles, if you were to ask them if they were Indigenous, they would say, what the hell does that mean? Like, what is that the new word this this decade or whatever? What does that mean? The only thing that I would not recommend if they said, yes, I'm Indian, that you're reflecting back. Oh, okay, so for Indian people, because of the negative I guess, history to that particular label. But they're all labels. I call myself a Chippewa. I'm a mixture of Mohawk and Anishinaabe. So that's how I refer to myself, as a Chippewa. And again, creating that space to ask the individual, how do you refer to yourself? What's your ethnicity? So I'm going to skip over a lot of this. It's just some reminders about the ask. Commitment, some of the wise practices, again, sharing back that information, that data, formalizing OCAP considerations, that co-learning. Commitment is also demonstrated in reaching into the Indigenous community. I've heard a lot from the Indigenous stakeholders. Why do we have to go out there and tell them how to work with us? Why can't they come here? So go to the friendship centers. At the end, I'm going to give you a list of some of the Indigenous stakeholders within each region, but go and visit. I mean, it's like welcome you into our home. You go into Fort Erie Native Friendship Center, you're going to be welcomed. They're going to be happy to be sharing information about their programs and services. There's a pride there in what we do to take care of our people. Definitely reach into our community to learn. I would like to caution against tokenism. So if you have one Indigenous person seated around your table, that does not necessarily mean that they speak for all Indigenous people. We need to look at the needs of the different nations. So in HNHB Lynn, we have 6 nations of the Grand River, which is Haudenosaunee or Iroquois. We have Mississaugas of the Credit First Nations, which is an Anishinaabe, Mississauga. And we also have our urban Indigenous population. You cannot take the same assessment of needs and apply it to all 3 of those populations because they're very different. So when you're looking at meeting the needs of the Indigenous community, make sure you get to know the community and engage with that community. So there's some suggestions later on what that engagement looks like. I do want to cover these 2 videos though in our time allotted. Part of that reaching in is demonstrated by this first video. What I hear often, so being in a role of advocacy, patient advocacy, I would hear a lot about complaints about service. This is what happened to me, this is what they said to me, this is, and I would hear it. I know an Indigenous community that if our community members were sitting around the table and beating, they're talking about their patient experience. If they're sitting at a congregate dining event, they're talking about their patient experience because they feel safe within their community and having those supports around them. Are they picking up the phone and calling patient relations? No. Are they going in and lodging complaints, formal complaints? No, but they are talking about it. So this first video is an example of reaching in based on the how they're speaking. I would guess that it was a northern community just because of the accent, but it's how patients will talk about their experience when they have the safety of that community around them, their own community.
Yes, I have experienced racism in our system with the doctor here and nurses. Nurses treat us differently. My file, every time I go there, like, I'd be there before everybody, and I thought it's first come, first served. But my thing would get, my file would get put to the bottom, you know, I'd have to wait there all day, and, you know, I could talk to one of the nurses, or talk to the doctor, you know, then, you know, they'd tell me, you know, go sit down, like, telling me to go sit down like a child, you know, I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient, you know, and, you know, they talk to one of them right away, and like, they tell me they're busy, and that's with the doctor and nurses that they do that. Oh, for one thing, you know, I like a different doctor, plain and simple, a different doctor, you know, and also better training for people skills for the nurses. You know, they seem not to have any people skills, you know. They get grouchy at us. The woman that sits at the desk that takes names and, you know, sets us up, she gets grouchy with us. You know, when I was there 2 weeks ago, I heard her swear and say effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes and she had, like I said, heart, kidney, and lung problems. And she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible that for a doctor to do that? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front there. Boy, I was amazed, and he just threw himself on the chair after he got that. And he was just blushing, just red. I just about swore at him, and then again he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Oh my God, you know the time I broke my knee? And then when I was there for 5 days, and the nurse was coming to give me 4s, and then I told her, can I get a pill and all extra strength instead of. She got mad at me and she went back to that where she keeps her pill to come and give me that pill. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on that pillow. She lifted my leg, put that pillow there, just dropped my leg. I was just being treated. Know what if I was able to walk, I said I would have walked on again. And I told my auntie so she gets the same treatment.
Well, a lot of old elders don't feel safe there. Like, you know, because like, you know, like I see elders when they're in the hospital, like when I walk in from my town, I talk with them. You know, they don't feel safe. They look scared, but they don't want to say anything. But they look scared, and you can feel that on them. You know, and that shouldn't be these are our elders. You know, they shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or or something to that effect where a person can actually just sign in and say this is what happened to them?
He's the only doctor he can see, so like what if we're really sick one time and he doesn't want to give us treatment because of that, and he won't do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now I'm mad to her, I guess, for what, I don't know. You should see the way she treats them, eh? They're very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians and stuff. I will go one of these days.
So we go back with that again to recognizing what that anti-Indigenous discrimination looks like within the healthcare system. It looks like lack of diagnosis, misdiagnosis, lack of treatment, and even death. The second video is about Brian Sinclair. I don't know if you've heard his story. Not all of our stories are elevated to public inquiries, national attention like Brian Sinclair's, but there is so many stories within our families like what you've heard, and even as serious as that of Brian Sinclair. So I'll just play this one to kind of close out.
He died after waiting 34 hours for treatment in a Winnipeg emergency room, and today disturbing testimony was heard at the inquest into the death of Brian Sinclair. He was an Aboriginal man. He was also a double amputee, and as Crystal Gamansing reports, many are questioning whether racism played a role in his death.
Security video shows Brian Sinclair at the triage desk with hospital staff. He goes to the waiting area. There he stays. An entire day passes and the double-leg amputee stops moving. It's now Saturday and Alain Remelard's working security. A stranger tells him a man in a wheelchair has been sick. Remelard's memory of that shift back in 2008 is fuzzy. He called housekeeping and video shows that. He also didn't have any interaction with the man in the wheelchair. While testifying at the inquest into Sinclair's death, Remillard said he assumed Sinclair was intoxicated and sleeping it off. The inquest started earlier this month, and many say this is an example of widespread racism.
We assume that kind of acts of name calling and those sorts of things constitute racism, but really it's those underlying assumptions.
The inquest has heard from a number of security guards working in the emergency department at the Health Sciences Center, including the one security official who discovered Sinclair wasn't sleeping, but was in fact dead. He told the inquest when he alerted medical staff, they thought he was joking.
Gary Francis testified Wednesday he tried to shake Sinclair awake. The security supervisor pinched him, finally tilted his head up, and saw his eyes were black and face very white. That was 34 hours after Sinclair entered the ER needing treatment for a bladder infection. It's believed he may have sat there dead for up to 7 hours.
It seems that oftentimes a culture of dismissiveness has prevailed over a culture of empathy and compassion.
Changes have been made at the emergency department and more could be recommended. The Sinclair's family lawyer anticipates more disturbing testimony to come when the inquest resumes in October. Crystal Gamansing, Global News, Winnipeg.
So when we look at why our Indigenous people don't engage, that's why. That's part of our narratives, part of our experience. I am happy to hear that they did mention that it was 7 hours before they realized he was dead. Imagine people walking around him in that wheelchair and not even noticing, not bringing any attention to the medical staff. One thing that came out of that inquiry as well, you seen when he approached the desk for triage, they wrote his name down on a piece of paper. They could never find that piece of paper. after that initial contact. So he was essentially ignored for that length of time. He was sent to ER by a community health center to have that bladder infection. I believe it was a catheter change or something that needed to happen, some attention to that catheter. So, you know, when we look at HealthLink's model of care and that improved communication between our Indigenous organizations and stakeholders and non-Indigenous led organizations like our hospitals, there's direct benefits to our patients in that. So in order to engage our community to participate in that wholly, in order to engage patients to engage in that wholly, the reality of that lack of cultural safety needs to be addressed. So there's some ideas in there about how to get some feedback about whether or not the care is appropriate or culturally safe for Indigenous people. When I go out to the Indigenous community and I say, what can I do? Like, what message do you want me to get put out there? I hear, Jodi, truth and reconciliation, truth and reconciliation, those calls to action. It's already documented what needs to be done. So there's highlights in here about those calls to action specific to healthcare, and some things to take a look at whether or not they're being put in place. One of the things, this one here, the cultural competency training. So the LIN funded course, and if you're going to at a later date purchase cultural safety training for your staff, it's great to have a general course like that, but you really need to have that experience where they can engage in that self-reflection. So those exercises where they're supported in recognizing the presence of negative bias and stereotype and kind of encouraged to work through that process of responding in a way that creates an ally to Indigenous people. So that's great that you got access to courses, that type of thing, but what I would encourage is you supplement that with information co-designed with the local community that encourages that process of self-reflection. Being in that ugly space, I mean, I still watch Brian Sinclair's those videos, and I just, like, it makes my skin crawl. But being in that ugly space to really recognize the ugliness of that reality and, okay, what can we do about it? That's what I'm talking about, that type of training. So there is that type of training coming to Niagara region within the next couple months, and I can certainly give some flyers and everything to that. And I'm hoping with the development of these Ontario health teams, it will be something that's ongoing process in that for all of those health team members. So there's some more about truth and reconciliation. So there's the resources that I mentioned. Those are all links to that. These are the Indigenous supports throughout HNHB LIN. It's not a completely exhaustive list. I would encourage you to demonstrate commitment, do your own homework, and going and clicking on the links and seeing what's available within our community. And I can have that sent out or with Amanda, whatever. So thank you. 1 o'clock. Perfect.
Jodi. Did anyone have any questions for Jodi while she's here? If you've got a couple minutes.
Yeah.
Anyone? Okay. Well, thank you very much for taking the time to talk to us today. We really appreciate having you, and we hope to hear from you again soon.
Thank you. Thank you. I don't want to send you off in that ugly space, so I'm going to give you some hope. There's been some remarkable things that have happened throughout HNHB LIN after conversations like this have happened. We've had hospitals set up community engagement events where they're going out into the community, like you've seen in that focus group, and they're asking, what are your stories? We've had hospitals and other non-Indigenous led organizations paying more attention to patient stories and saying we want to be able to collect those patient stories to inform our leadership. There's cultural safety training both at that frontline worker level but also at that system level, and we've had hospital board of directors come and say we want to put our board of directors and we want to put our management staff and our leaders in that full day training to learn how we can create culturally safe human resource policies, culturally safe spaces within our hospitals, culturally safe governance models. So there's a lot of good work that's happening. I don't want you to leave thinking that it's all doom and gloom because there's been some good strides made. Thank you.